And sorry to pull you away from the TV, but as Tom said, I imagine we'll be getting a look at it a few times over the next couple of days, so not to worry. Thank you, especially to our presenters, Tom, Jean, and Susan, for taking time out today to chat with us and share their pearls of wisdom on telehealth. And I finally have just started doing telehealth, and it really is awesome. I don't see myself going back into the office unless I have something really going on. So it's been very convenient and very, very painless. We have our circle, any of our circle of friends here on the call today. I know I see Susan's name. She's trying to get. Are you in, Susan? Maybe not. Do we have any circle of friends that have been able to tune in yet? Looks like she's having trouble getting in. Yes, we're going to have you guys. John is going to introduce your bio, and then you'll have an opportunity to speak. But I was looking to see if we had someone that wasn't speaking today. If they come on, we'll put them on at the end. Wanted to remind all of you that are on the call today, we have a 6 o'clock town hall meeting tonight with Dr. Alina Alonso, and she'll be talking about the vaccine. So if you have questions, please email them to us ahead of time. There'll also be an opportunity to raise your hand, I'm sure, at the end of the meeting. Mindy, correct me if I'm wrong, but we have about 75 people signed up for that tonight, so I hope you'll join us as well. Without any other plugs for this, we have John Dalton, who's a circle of friend and is our unofficial Healthcare Connection MC, and he's going to talk to you about Optimum and then introduce our three speakers.
Well, thank you so much, Deanna. My name's John Dalton. I'm the owner of Optimum RTS, which is a full-service medical employment agency serving not only Southeast Florida, but all of the nation. We have three other Circle of Friends superstars that have been part of the Medical Society for a long time. We have Tom Murphy, Susan St. John, and Jean Acevedo. They'll all be talking to us today in regards to our topic, which is additional risk issues and mitigation for increased use of telehealth services in your practice. To start us off, we're going to start with Tom Murphy. Tom Murphy specializes in professional liability, workers' compensation, regulatory, and cyber coverage. He is an experienced risk management consultant providing physicians and various medical entities with the risk claims management techniques and implementation. In addition, Tom performs malpractice claim studies for medical specialty societies and maintains an advisory position for various societies, including malpractice claims and workers' compensation claims. He is often a guest lecturer for various medical societies and associations. Tom, thank you so much, and take it away.
Thank you, John. As always, first and foremost, I just want to take this time briefly to thank the Medical Society, as always, specifically Deanna and Mindy, for putting this together. And for all that you do for our physicians and medical practices. So thank you. And John for always being there to help us out with this stuff. I'm going to talk briefly today, right there on your screen, about risks associated with telehealth. And one of the things I wanted to state first is we throw around the terms telehealth and telemedicine. And I always have my clients ask me, what's the difference? And there is a difference. Telehealth is the overall function of any type of virtual medicine. It could be anything in the medical world. Telemedicine is more specific. It's when you're dealing, whether it be by phone or Zoom call or any other type of virtual contact directly with a patient, the provider and the patient. So that's the difference between telehealth and telemedicine. And we're going to talk for a few minutes about those risks associated with that. And after I'm done, Susan is going to expand on some of these issues with some of the more important things you need to be concerned with and looking for in your practices as we all now branch out into this virtual world. And so, if you would, Mindy, next. The key here, which I'm not going to go into, I'm not going to delve into because I know Susan will be talking about this, is, you've really got to know your federal, your state laws, especially when you're doing any type of telemedicine or telehealth across state lines. This is really important. I know that during this whole pandemic, the federal government, as well as many other entities, state boards of medicine, et cetera, have loosened up the guidelines for telehealth and telemedicine to help expedite and make sure that people were getting the necessary treatment that they needed. Those things are going to start to change here. They already have. So it's really important for any practice, any provider, to really check into, the licensure and guidelines as you move along. And obviously part of doing that is checking with use your resources. And when I say resources, of course, I'm talking about Board of Medicine, your societies like Palm Beach County Medical Society. They're the first place to go to kind of ask. And if they don't know it, they're going to refer you to people like us, and especially to people like Susan at the Florida Healthcare Law Firm and her team, who are really a great resource. And then, of course, to Jean, who everybody knows is another great resource. And it's funny because I always tell my clients, look, it's tough in a medical practice, especially today with costs and everything else, but you're so much better off paying for the right people up front, because paying a little ahead of time is going to save you money down the road. So having people there for you and these resources like Susan, her team, and Jean and her team are really going to go a long way to help you navigate all this stuff. Mindy, next, if you would, please. So obviously, we always talk about implementing best practices. That's no different when it comes to telehealth. You really have to, as we just talked about, the resources, using your resources, you've got to determine for your practice what is going to be best, in terms of your best practices and your standard of care. And not only dealing with your staff, but dealing with the remote. There may be other physicians and medical practices involved, and all of that has to be tied together. Another great resource that we tell people to go to with all of the telemedicine going on is the American Telemedicine Association. I'm sure there's a bunch of others out there, but we've referred a bunch of our clients to them because they are a landing spot now for a lot of these guidelines and state regulations and other things and protocol, more specifically, that you need to be thinking about when you jump into the telemedicine world. And so really important, and that's a really great resource. So obviously the website's not there, but if you Google American Telemedicine Association, you're going to be good. Next, Mindy, please. So obviously another extension of what we were just talking about is the credentialing, making sure that everybody you're working with, not only in your own practice, but in other practices, are qualified as they should be, and they have the proper privileges and applicable. They're following the proper applicable laws, et cetera. Really important. I can't stress that enough. Next, Mindy. Okay, so another part of that is obviously your selection criteria for clinical protocols in the telehealth spot. And really important, obviously with that, you're going to find this information with people like Susan, with Jean, also the other resources we were talking about. Very important that not only the provider or providers in the practice are following this, but all of the employees, which I'll talk about briefly in a moment, is training within your office, within your medical practice of the entire staff. It's no different than the training that you're going to have for your on-site medical treatment. It just is going to, have differences because of the virtual nature of it. So next, Mindy, please. When you have multiple providers that are involved in the patient care, once again, everyone's got to be on the same page. Each provider's got to know their clinical responsibilities at the originating and the distant sites. And there's got to be, we say this all the time, the communication. I don't care if it's, regular on-site treatment where a patient has multiple providers for multiple care. The same is going to hold true for virtual. Everybody's got to know their part and know what they are expected of and what is expected of them, especially when it comes to adverse events with the patient or conditions, et cetera, but everybody's got to know their accountabilities. Next, please. So we've already talked about protocols and the communication. Once again, I think to me, it's really important that any of the treating physicians or providers, whether it's PAs, NPs, et cetera, even nurses, that everybody is communicating. And you've got to take the time and make the effort to communicate so that the care is coordinated and that the patient is receiving the best care and that it falls within the standard of care. Next, please, Mindy. Okay, so really important here is, getting back to the basis of this virtual treatment and telehealth is your technology. First and foremost, technology has got to be HIPAA compliant, and I'm sure Susan will talk a little bit more about that, and possibly even Jean. But the number one thing is you've got to be, any system that you have has to be HIPAA compliant. So if you trust your IT people and they're doing a good job for you, that's one of the things you want to make sure of right off the bat, is make sure that that the system that you're using is HIPAA compliant and protected. There are the proper controls in place, and that only the people that are supposed to be using the system are using the system, et cetera. We all know about cyber issues we see and read every day. And you've heard us talk about this many times, where medical practices are highly sought after by cyber criminals. And so now that everybody's become more virtual, almost overnight, not that telehealth and telemedicine weren't here for years, but it's accelerated so dramatically that it's becoming a real issue. And the companies that we work with from an insurance standpoint are seeing a huge influx of claims now with people, not only medical practices, but remote employees, et cetera. So really, really important to sit down with your IT people. And if you don't have good IT people, get good IT people, because that's the start of everything. And they are going to, a good IT company will get you doing what you need to do, HIPAA compliant, and having the proper controls in place so that you are less and less likely to have an issue with the telehealth that you're performing. Next, Mindy. So getting back to, actually I should say expanding on privacy and security. You want to have, and this is where our company comes in, you want to have not just your IT company, but you want to have a company for insurance coverage that protects you, not only if you have a claim, but is proactive and actually can go in and look at your system ahead of time before they provide you insurance, see what's going on, and make any recommendations if there are issues. We have that. We've, after a number of years, we've teamed up with a great partner out of Atlanta called the Coalition. And this is a team that's been put together over a number of years of some of the top cyber people in the country, both good and bad side, CIA, FBI, et cetera. And literally this company comes in ahead and they'll come in and look at your system. They're not going to go in and do anything to your system. They're going to look at it from a surface level, and they're going to determine if there are issues with your system. And if so, they're going to tell you how to fix them, and they can help you fix them. Then after that comes the insurance coverage, where you're now protected if something does happen. But along the way, they're proactive. And what I mean by that is, as you're going through the year, and if they see anything that your system needs, like a Microsoft patch or something that needs to be done, they're going to notify you of it. So they're on top of it 24/7, which in this day and age is really important. Next, Mindy, please. All right. So as I said earlier, training, utmost importance here, with your providers and your staff. Once you've put the systems in place and you're doing what you need to be doing, you've got to sit down and train your staff, have a meeting or multiple meetings to talk about the technologies, the scope of the type of telehealth you're going to be doing, who can do what, as we said earlier, the services that are offered, equipment, and then obviously maintenance of the system. and make sure that everybody's on the same page with that. Next, Mindy, if you would please. I'm not going to go into this too much, with regards to incident reporting. But obviously, if you have any issues, whether it's direct patient issues, it's no different than anything else in terms of reporting. Obviously, when things are, when they're affected by potential HIPAA issues, we all know that that's got to be reported properly and in the right manner. And Susan and her team can help you with that, to make sure that you're doing everything compliant, as they say. And with that being said, I'm going to pass this off to John to introduce Susan, who I know will expand on this and help you with navigating some of these things that I just talked about. And then, of course, Jean is going to help you all with, the most important thing is how you get paid. So thanks again.
Thank you so much, Tom. Thank you. I appreciate it. And now I'd like to introduce Susan St. John. Ms. St. John's practice focuses on healthcare law, business planning, tax law, civil trial law, and includes the following: practitioner representation before the Department of Health and various boards, provider representation before the Agency for Healthcare Administration and the Centers for Medicare and Medicaid Services, CMS. Mergers and acquisitions of healthcare providers and physician practices, preparation and review of telehealth agreements, physician agreements, practice buy-sell agreements, and diversities. Preparation and client memorandums for health law, tax, and law issues. Preparation, review, and negotiation of contracts and settlement agreements. And entirely formation of operations and entity dissolution. Ms. St. John has represented clients before the Florida courts, including the First District Court of Appeals, the administration tribunals. She serves a wide range of healthcare-related entities, both for profit and nonprofit, such as physician and physician group practices, home health agencies, nursing homes, behavioral health centers, hospitals, surgery and imaging centers, telehealth platform providers. Prior to becoming a lawyer, Ms. St. John's enjoyed a career with the healthcare financial consultants with Ernst & Young and various hospitals as a Medicare auditor. She has over 30 years experience in the healthcare industry, and that's because she started working at 17.
I wish that part was true. Thank you so much. I appreciate that. So just kind of going forward with what Tom started with and trying to mitigate your risk when you're having telehealth as part of your practice. And Tom's alluded to already, one of the things that's incredibly important is vetting the telehealth platform provider that you choose. Most practices don't try and do their own telehealth platform, but they look for one that they can license from a reputable telehealth platform provider. So just as Tom was mentioning, one of the things that's going to be very important is the HIPAA compliance component of your telehealth platform. The other is the technology. You want to have reliable two-way audio and video communications. You're going to need an end user agreement. That's something you're going to sign. You're also going to want an agreement for your patients to sign so they understand how telehealth visits work and any type of risk there might be associated with a telehealth visit as opposed to an in-person visit. And one of the risks there is really about security. And telehealth platform providers, the reputable ones, have programs that are HIPAA compliant and are as secure as they can make them. What they cannot secure is the outside hackers, and we know that that happens. So that's something that patients have to be aware of so that they can make the choice on whether they want to have a telehealth communication or not, because they're going to be sharing protected health information back and forth with you. The other thing you want to find out is, does the telehealth platform provider service have a way that everything that you do via the telehealth communication, does it have a way to interface into your EMR system, or does it have its own EMR system that your practice can use for all of its EMR needs. And that becomes really important because one of the things that's difficult is some of these telehealth platform providers, they have an EMR system that goes with the platform, but it doesn't interface with your EMR system at your office. So now you've got two systems and you're trying to keep records from two systems on one patient. So you want to see if those can be interfaced. And often they can be, and the platform provider has thought about that, and they have their IT team that can help interface and use your IT team to interface into your EMR program. And again, that's, we all know how important keeping medical records are and the diligence of keeping medical records and making sure you have, properly noted everything and put it in a medical record and are able to have a concise, complete recording of everything you've done for your patient, whether it's in person or whether it's telehealth. So those are some of the considerations in vetting a telehealth platform provider. The other thing you're going to want to know about is cost. How much and how does that platform provider charge you? Most of them are a licensing fee. And then you want to look at the licensing fee. Is it a flat rate for just the use per month, no matter what the use is? Because some of our practices are not using telehealth routinely. That's not their primary mode of treatment or visitation. So what they'll have is maybe a day they do telehealth or a morning they do telehealth, but they're not using it routinely. And so how are they charged? Is it still going to be the same flat fee? Some of the telehealth providers have a sliding scale based on the usage of data. So you have to look at those things and determine what's best for you and what fits your budget. Those are just some practical things to think about. And of course, you have to have the right technology. You have to have the right software. And the telehealth platform provider is going to help you with that. But you also have to have the right hardware. And telehealth platform provider can also help you with that because they'll tell you the minimum requirements you're going to have for the platform. So one of the other things as you are thinking about or forging ahead into telehealth and seeing patients through telehealth is obtaining proper patient consents to have visits via telehealth. That's very important. Just like any other informed consent, the patient has to understand the benefits and the risk associated with a telehealth visit. And of course, sometimes the risk is maybe you don't see everything you would have in person. The other risk can be there can be a element of a privacy issue because of communication. While your program, telehealth program, and your equipment is going to be very secure, you're going to make sure that, as Tom talked about, you don't have control over the patient's equipment and tools. And so that's something the patient has to be aware of, that there are those chances that things can leak out, so to speak, and they have to be aware of that. The other thing, just as a practical sense, you want to know how you're going to be paid. If they have insurance, you're still going to file claims. If they have a copay, how are they going to pay that if the patient is at home and you're in your office? And so you want to have some type of agreement with the patient on payment. And usually what we see our providers or practitioners doing is having credit card authorizations that a patient will keep on file and is actually linked into their telehealth platform account. The patient has to have login credentials as well as, of course, the practitioner. And each practitioner, any practice, has to have separate login credentials. You can't share that back and forth. And so if you have a practitioner leave your practice, you have to deactivate their credentials immediately. So you want to make sure that you're thinking about all of those things to keep the integrity of the security, but also to keep payment flowing to you. If you have Medicare patients and you're going to be offering non-covered services through telehealth, and ones that are not statutorily not covered, but non-covered, that would be the patient's responsibility, you want to make sure you also get those ABN forms signed, make sure they're updated, and make sure they include the telehealth visits. And just for a minute about Medicare, we know that in the past it has been only rural patients, and they have to be at an originating site, and there is a distant site provider. That's been flexed for COVID. The patient can be at their home. And again, that it's, I think, going to change after COVID, but we're still waiting to have some of the laws changed so that we have more flexibility in treating that patient population, the Medicare beneficiaries, that is. Other patients who are non-Medicare, it depends on the insurance, and Jean's going to talk about that. But as far as the state law goes, in Florida, they don't have to be at an originating site provider. Patient can be at their home. I do telehealth visits from my home. It has been fantastic during COVID because I still get to have my appointments with my doctor, and we have good communication. It's very clear, and everything I need done is done, and the appointment goes very well. So again, that depends on what type of appointment it is. That's another risk factor. Is it an appropriate appointment for a telehealth visit, or should you see the patient in person? And so that's, that's a decision you have to make. For mental health patients, often telehealth has been encouraging patients to keep their visits and not cancel them. Sometimes our patients who have mental health issues tend to cancel because it's either a hardship to get to the appointment, or it is just a psychological feeling of somebody's watch me walk into a mental health practitioner's office, and it's hard for them. So telehealth for that segment of practice has really been fantastic because the mental health practitioners that we have in our client base are seeing greater compliance, and that's a great thing. But again, it depends on, is that an appropriate visit? And a lot of times, yes, for mental health, but if you had someone who had an injury to their knee, it wouldn't be appropriate. You want to see that person in person to evaluate the extent of the injury and what their needs may be. Again, going back to patient consents and some of the risks you'll see, your patient consent needs to clearly tell the patient that telehealth services are not for emergencies, that they're having an emergency, they need to get to an ER or call 911. So that needs to be clear in your patient consent, so you don't have patients trying to use telehealth services if they're having something that might appear to be stroke symptoms, or if they're having chest pain. That would be something, as a practitioner, you want to make sure patients have that understanding. Things that are urgent and need to be seen in person, that's exactly what needs to happen. So again, some of this is about patient consent, but it segues right into standards of care and best practices. And you want to make sure you practice within your standard of care and implement best practices, whether you see someone via a telehealth visit or in person. So you have to ask yourself, when you're setting up the appointment, would you do anything differently if the person was seeing you in person? And if the answer is no, I can do everything through telehealth that I would do in person, then that helps you make a decision of the telehealth appointment being appropriate. But always ask yourself that question. Look at the patient's record and see, is this something I should be doing? What about new patients? You want to get as much history and physical as you can. And remember that in the state of Florida, a telehealth initial communication can establish the patient-practitioner relationship. But again, you want to make sure that you're doing a valid assessment. As much as you would do in the office, you want to do on telehealth. And certain practices lend themselves for that to work very well. And other practices, if your orthopedist who have to actually look at something that's been injured, that won't lend itself well to it. So you have to think of those things. What's the best practice? What's in the patient's best interest? And ultimately also what's in your best interest, because everything you do as far as seeing patients goes to your license. And you want to make sure you don't have a misstep that might cause a complaint to where now we're having to defend your license. So those are things to think about. We talked a little bit about communications. Tom talked a little bit about it. I've talked a little bit about it. Two-way audio video is a best practice, although during COVID, we know that the audio only communications have been acceptable. But again, there's a benefit to being able to see the patient when you know it's the patient. You hopefully have some identification already on file, so you can match it up when you're looking at the person through telehealth. And you have assurance or more assurance that you're actually dealing with the patient that is signed up for the appointment and not somebody else that's just speaking to you over the phone on their behalf. So I think, in my opinion, two-way audio video is a best practice, but there are times when audio only is appropriate, and you just have to make a determination on that on a case-by-case basis. And then also you have to look and see, is it going to be permitted by law? During COVID, it has been, but ordinarily in the state of Florida, it must be two-way audio and video communication. And then for our Medicare patients, a lot of times it is two-way audio and video communication, although that's been relaxed a little bit with some of the virtual check-ins and something and so on, and e-visits. Again, same standard of care applies. You want to make sure you're following the Practice Act and implementing best standards and best care for the patient. So then a couple of other things we have come up a lot in our law practice that our practitioners are asking us, what about controlled substances? So controlled substances, it's an interesting component right now, especially during COVID. There's been some flexibility by the DEA with prescribing across state lines. And then of course, each state has been more flexible with its telehealth laws to make sure that needs are being met for folks to, stay home and stay safe and stay out of the community to be, contracting the virus. But one of the things to keep in mind, federal law does prevail over state law when it comes to controlled substances. When we go back to post-COVID, the law has not yet changed. There's still an initial in-person visit that is required before you prescribe a controlled substance. Once you have that initial in-person visit, then you can prescribe using telehealth, and that's set out in the United States Code. Each state has a little bit different take on that. Florida does not allow, when we go back to post-COVID, it does not allow for controlled substance prescribing via telehealth unless an exception applies. And exceptions are hospices, nursing homes, hospitals, and treatment of mental health disorders or illnesses. Those are your exceptions. So if you're treating somebody for pain, you're going to have to treat them you're going to have to see them in person once we go back to post-COVID, once our public health emergency is over. So that's something you want to keep in mind. We get a lot of questions about that. We get a lot of questions about testosterone prescribing because that does help with wellness. The same law for opioids and telehealth prescribing under the federal law applies to testosterone. And also in Florida, there's no exception in the Florida law for a controlled substance being prescribed to a patient via telehealth, except for one of the 4 exceptions that we just mentioned before. So you have to keep that in mind when you are prescribing. Now, one of the things that the DEA did for COVID was they allowed practitioners who are DEA registered in one state to be able to cross state lines and prescribe in another state, whether they were invited by the other state to be there physically to help out with the COVID load, or whether they're providing telehealth through some exception due to the public health emergency. So DEA has allowed that. Ordinarily, you have to be registered with DEA in each state that you are going to provide services to a patient where you will prescribe controlled substances. There's been some misconception that the DEA registration is a national registration, not for practitioners. It is state by state. So it's just something to keep in mind when you're thinking about all the things you have to think about in doing telehealth prescribing and crossing state lines, which we have a lot of practitioners that happens with just because of being South Florida and having the snowbirds that come down. They're here for 5 or 6 months and they go back to their homes up north, and can you treat them? And the answer to that question is maybe. Again, you have to look at each state's laws to see if an exception applies. If you're licensed in that other state, you should be able to. If you are not, does an exception apply? COVID has been a big exception. A lot of states have relaxed their licensing requirements so that practitioners can cross state lines and practice telehealth, just like Florida has. We know Florida has a registration process for those who are not licensed in the state under the statute. But during COVID, they've waived the registration so that more practitioners can offer services to Floridians to make sure that people are accessing care timely. What the Florida waiver didn't do was allowed controlled substance prescribing by those who are not licensed in this state. So while it allowed practitioners to come in from other states via telehealth without registration or licensing, it doesn't allow for controlled substance prescribing. So there are going to be states like Florida where you want to be able to provide services to your snowbird patient or just during COVID to help out with a load in another state. And you really have to look at each state's emergency orders. Is there a waiver in place? And then past COVID, we're going to have to look at each state. And there are resources, just like Tom has said. Some of those resources are summaries, and you really need to drill down into the statutes, because once you start drilling down, you start reading a little more closely that maybe I actually can't do this. And you want to be very careful about relying on a summarization of the laws and not having somebody actually look them up for you and tell you, can you do that? Would that be okay? Or will it be a violation of a practice act in another state? Which then becomes a problem for you in this state, because if you get reported in another state, it's going to get reported down here. So you want to keep that in mind. So, and the last thing that we actually get a lot of questions about, again, it's under controlled substance genre, is medical marijuana. Can you certify a patient via telehealth for medical marijuana? No, you cannot, not even during COVID. You can recertify a patient that you have already certified during the public health emergency caused by COVID, but otherwise, no, those all have to be done in person. And again, if you're looking at doing that in another state, you're going to be looking at, am I licensed there? And will that state allow me to do that type of work via telehealth? And again, it's a state by state check. And some of the states will allow telehealth certification and others, most of the others will not, but there are a couple that do. So those are some of the things you want to keep in the back of your mind as you're going forward. One other thing, I know Tom probably alluded to this, but I want to make sure everybody understands that if you pick up telehealth, it's part of your practice. And I think most of our practitioners are now. Please make sure your insurance policy covers telehealth visits and covers the communication, covers the things that possibly can go wrong. We want to make sure that if you decide that you want to implement telehealth, before you start implementing telehealth, check with your insurer and see if your malpractice covers it. So with that, I know there's a lot about coding and billing and how you actually get paid besides the payment from the patient who's having to pay out of pocket. And I'm going to turn that over to Jean.
John, you're on mute.
Thank you.
There you go.
Susan, thank you so much for all of the insight that you provided to us. It was really appreciated and certainly in depth. I'd like to introduce Jean Acevedo. Her acronyms behind her name: LHRM, CPC, CHC, CENTC. And she also started working at 17, giving her 30 years of healthcare experience. She has a particular experience in chart audits, compliance, and education relevant to physician documentation and coding. Jean has also been an expert witness for civil litigation and investigative consultant for the DOJ and federal fraud cases. She is a workshop presenter for the American Academy of Professional Coders and a co-author of the Academy Compliance Toolkit, a member of the Advocacy Board for Parses, Inc., and an instructor for the Florida Atlantic University and a member of several Coding Institute Educational Advisory Board. Jean has been a participant in the CMS Medicare Provider Facebook group, CMS Division of Provider Information, Planning, and Documentation since 2007. And she is also a member of the Jurisdiction 9 MAC Provider Outreach and Education Advisory Group. She is a frequently sought after speaker, and she possesses a unique perspective for avoiding risk and liability while optimizing reimbursement in the highly regulated healthcare industry. Jean, take it away.
Thank you, John. And
You're
Tom,
welcome.
Susan, thank you so much for that good information. I was sitting here listening going, oh, I didn't know that. Oh, I didn't think of that. So I'm hoping that the rest of the folks listening had that, had a couple of aha moments or pearls. So as Susan alluded, I'm going to talk about, all right, well, we are in this public health emergency. And what is it that you can get paid for, especially on the Medicare program? And from a risk perspective, since we have in my little group managed to continue to conduct some chart reviews, what are the risks that we've seen that maybe doesn't get documented? So first, know that we are indeed still in a public health emergency. On January 7th, the then Secretary Azar of HHS extended the COVID-19 public health emergency for another 90 days. So I believe that brings us to about April 20th. February is a short month, but March is not, I think. So it's about April 20th, somewhere around there. So all of the leniency that the CMS has allowed for the services that can be provided and they'll pay for during the public health emergency will apply during this time. In the final physician fee schedule rule for 2021, CMS did also list out the services that would, one, be permanently added to the list of telehealth services, and probably a more important list for our purposes is what are the services that were only temporarily added, such as telephone calls, that audio only, that might continue after the public health emergency ends, but only till the end of that calendar year, right? So that if the new Secretary of HHS, let's say on April 19th, realizes that, oh shoot, I haven't extended the public health emergency and does it or doesn't, that we don't have more than like a day's notice to suddenly change practices. So what are the services right now that are payable through the telehealth benefit? And you know, before I forget, if you were to go to cms.gov and probably in their search bar, just put in telehealth codes, you'd come up with a list. CMS has updated an Excel spreadsheet with currently covered telehealth codes, probably no more than 4 times in the last, 9 months or so. And they've actually, the last time, added a column that never existed before, which is audio only. Because in addition to what we think about as telehealth, and when you all are probably doing telehealth, you know, the phone calls, an office visit where the patient is being seen via DoxyMe or Skype or FaceTime, et cetera, or WhatsApp. The telephone calls and advanced care planning and some other services are not telehealth in the traditional sense at all. Never mind, is there no originating site? You're not seeing, you may not see the patient. So there's a column that says yes, if those are allowed audio only. So the telephone calls are on there for now, and other services, including things like advanced care planning discussions. So what is actually covered? The typical office practice, office visits. And as I'm sure you all know, and that the way you even choose the level of office visit has changed dramatically this year. Know that deciding what level of evaluation and management service for an office visit code using the new 2021 guidelines is the same whether you see the patient in person, so they have gotten to your office, or you're seeing the patient while they're somewhere else, but billing an office visit for telehealth where there is audio and video. No longer do you have to worry about documenting a full physical exam, a complete review of systems to choose the level of your evaluation and management office visit code. It's either how much time did you spend or what's the complexity of medical decision making. Boy, was that a Cliff Notes version of the new guidelines. So we have office visits, and if they're provided in place of an actual in-person office visit, in other words, outside of the public health emergency, where would this patient have come to see you? In the office, you bill an office visit. That's the way the Medicare program has looked at it. Where would the patient have normally been seen if you weren't using this new relaxed version of telehealth? For the Medicare program, to let them know that it was telehealth, the billing would go out with the same place of service. So place of service 11 for office, if it's an office visit, modifier 95. Just tells the Medicare program, this visit was provided via telehealth, audio and video. No payment differential, thank goodness, that's a nice thing. And that's for that. Now, Susan mentioned consent, thinking about it, I think from another perspective, the risk perspective, from a payment risk perspective, the Medicare program also expects that you get consent from your patient to be seen via telehealth or any of the other virtual services. So patients not coming to your office, you're on the phone, you're emailing them, you're providing an office visit via telehealth. They do expect that there'll be a consent. You do not have to get a consent each time you see them, not from a billing perspective. One time, once per year is sufficient, at least during the public health emergency. Documentation, obviously the same as if you were seeing the patient in the office. There's no requirement, but I do recommend that whatever the technology or the platform is that you're using, you should document that in the record. My fear would be that 2 years from now, Medicare or another payer asks for your note, and the patient gets wind that they've requested records. Sometimes, patients get calls from the payers, and they say, wait a minute, I wasn't even in Florida in June of 2020. I didn't have an office visit with this doctor. And if the doctor, nurse practitioner, PA has not documented in their record that this was telehealth via, just stick in the platform, the technology that you're using, then you could get into one of those back and forths that's a lot easier to prevent with a little proactive. So what about the patients that do not have the ability to have audio and video, or they just can't manage that technology? This is why the telephone codes that have been around since about 2008, during the public health emergency, were suddenly covered services and put on the list of covered telehealth services. So if you're, I was going to say seeing the patient, but that obviously would be an oxymoron in my example. If you're having your visit with the patient just via telephone, audio only, yeah, you should document that as well, right? So that it's really clear. It would also explain why you didn't have a physical exam for the patient today, not even by observation. Make sure that the patient's consent to be seen and treated that way is also documented. And there are 3 codes for the telephone only: 99441, 99442, and 99443. The only difference between the 3 codes is the amount of time you were on the phone with the patient. What do you think that means that you have to document? The amount of time. And I will tell you that routinely on chart reviews over the last almost a year now, not having time documented is probably the biggest deficiency that we see in the documentation. So think about it. If you were on, and a 99441 is 5 to 10 minutes, 99442, 11 to 20 minutes, and 99443, 21 to 30 minutes. So you bill a 99443 because you were on the phone with the patient for 25 minutes, right? You didn't document the time. What's going to happen? Well, at best, you're going to get paid a 99441, right? The payment, at least for Medicare, of these 3 telephone visit codes have been mapped to the level 2, 3, and level 4 established patient office visit codes. Something else that I need to interject, that only during the public health emergency are telephone calls and virtual check-ins and the office visits via this technology, not with originating sites, et cetera, allowed for new patients. Even if when some of these services remain on the telehealth list for covered services after the public health emergency, Many of them will revert back to the actual definition in the code themselves. So like for the telephone visit codes is evaluation and management of an established patient, over the telephone, 5 to 10 minutes. Right? So right now, the CMS is allowing new patients to get most of these services as well, definitely these that I'm speaking of. Again, for the reason that I think Susan was alluding to, is to make sure that we don't have any more contact with potential exposure to the COVID vaccine than necessary, right? So CMS, although they didn't do it initially, realized by mid-spring, wait a minute, if we only allow these things for established patients, the patient who needs to establish care with the doctor, so would be a new patient to that clinician, how do they get care? We're exposing them, right? So it made good sense. The other telephone service would be the virtual check-in. Now, virtual check-in, HCPCS code G2012, existed prior to the public health emergency and was a payable Medicare service, and will remain after the public health emergency as a Medicare covered service. The difference between that and the 99441, the 5 to 10 minute visit via the telephone, is that for virtual check-in, it's just that. It's the patient is checking in. So the patient calls, the doctor, the billing provider speaks to the patient, even if you're calling them back, only to determine next steps. You're not actually treating or managing anything with the patient. It might be that the patient says, I know I had an appointment next week, but I've been having these headaches, and, and the doctor asks about, have you been taking the whatever medication? And the patient says, well, no, I forgot. Well, take that and I'll see you next week as scheduled, right? No real management, just, no, you're all right. I'll see you next week, or no, you do not need to make an appointment, or yes, make an appointment. Then you can build a virtual check-in. This isn't impacted by the public health emergency, other than this brief check-in, this virtual check-in is allowed now for new patients. Once the public health emergency ends, it'll revert back to the verbiage in its definition, which is established patients only. The fourth type, because I've gone over, the telehealth audio and video, telephone, the virtual check-in, the fourth type of telehealth or virtual services that the Medicare program has allowed during the public health emergency is their online digital evaluation and management. This is a confusing code set. And in fact, the only time I've seen any physicians billing that code, the doctor had actually done it wrong. She didn't mean to choose that code. She actually meant to just charge for the telephone visit. And the reason that it's confusing and also not highly used is that these are evaluation and management services with the patient that the patient initiates online through your portal, right? And I know doctors are always telling me that the patients aren't using the portal and you're sure not treating them through that. But if you should, the patient base gets younger and younger, and even the Medicare patients are younger and younger from a savvy perspective than they used to be. So if I reach out to you, my doctor, with an issue, and you get my message from the portal, from your clinical staff, and you respond to me back through the portal, I get a message. And over the next up to 7 days, we correspond to manage my problem. You get to bill one of the online digital evaluation and management services. And they are also time-based. The time mirrors the telephone calls. So 5 to 10 minutes, 11 to 20 minutes, 21 to 30 minutes. But this is now management via an online mechanism rather than just a telephone. All of these require patient consent at some point in the record. Again, it can be once a year. So one time. I've often advised providers and their staff during this period, update your new patient paperwork, right? You've got your financial forms. You may have a patient consent form of some form. You've got your HIPAA notice of privacy acknowledgement, et cetera. Add this type of things that the patient will acknowledge that they consent to be treated virtually via telehealth, telephone, et cetera, whatever the options are. You don't have to document it each time. So that is the other thing that we often don't find in the clinical charts, the consent. So time-based codes such as telephone audio only, 5 to 10 minutes, 11 to 20, 21 to 30, and the online E&M. Both of those are time-based. Make sure you document your time so that you're not downcoded on a chart audit. So the only other thing I want to talk about is, so I printed out from a couple of slides from, is it next Friday, a week from Friday, is the 29th, the session the Medical Society has been doing on the coding updates and Medicare rules for 2021. And here's what will be added permanently to the list of telehealth services. So public health emergency is over. That's it. We've all been inoculated, right? And we've got this herd immunity, so we can go about our business, get back to whatever the new normal is. Excuse me. What services have been added to the list of covered telehealth services that will remain regardless of any public health emergency? Group psychotherapy, low-level established patient home visits, low-level established patient ALF visits, cognitive assessments and their care planning services. You know, there's a new prolonged service code, right? For office visits, G2212 in the Medicare program, each additional 15 minutes that you can use if billing a level 5 office visit based on time, because office visits have always been and will remain on the list. The new add-on code for prolonged services is also, and psychological and neuropsychological testing. Those are the things that will remain on permanently. The things that will remain on the list of covered telehealth services from a Medicare perspective, temporarily. So the end of the public health emergency and then to the end of the year. So let's cross our fingers that actually means 12/31/21. Mid-level ALF visits and mid-level established patient home visits, nursing home discharge day management, psychological and neuropsychological testing, physical and occupational therapy services. You know, the therapist can indeed perform some of their evaluations, et cetera, via telehealth during this time. Hospital discharge day management, and then any pediatricians listening, inpatient neonatal and pediatric critical care, or continuing neonatal intensive care services, and then just the general critical care services, and subsequent observation care. Anything else that is on the covered services list today that I didn't mention will be gone, right? Public health emergency is over. No longer will they pay for a new patient home visit. Why won't they do that? Patient needs to go back to the traditional telehealth where that patient who's at home goes to an originating site, right? So some of these old rules will come back in place as well, and there are others. So make sure that you document time when the codes are time-based. Make sure you document consent, not only from all the risk areas Susan was speaking to, but it's a payment requirement for the care that you provided. Document as you always would, as if the patient was being seen in person, face-to-face. Consider all of the areas that the 2 prior experts have talked about. I don't know that I ever would have realized that the DEA for controlled substances wasn't national, right? That it actually mattered by the state. And since we are indeed in South Florida with the snowbirds, if the patient says, no, I'm at home, make sure you know whether or not that means in Weston or in a state that you have to be concerned with, et cetera. Real important things to be concerned with. And I think that's all I had on the payment perspective. Thank you, thank you.
Jean, thank you so much. We really appreciate your knowledge. As always, Jean is one of our best presenters and one of the most knowledgeable people in Palm Beach County when it comes to reimbursement and the nation. So Tom, thank you. Susan, thank you. Jean, thank you so much. I know that Deanna, do you want to go to Susan?
Susan, did I? Me too? No, I was just going to say, don't forget to tune into Jean's Healthcare Connection on January 29th, noon to 1:30. It's a free Zoom meeting and you have lots of great information.
Excellent. And thank you, Deanna. Susan, are you there to introduce yourself for a Circle of Friends introduction?
Oh, yes. Susan Kaplan, are you there? She was here.
Going once, going twice. Thank you so much. Deanna, you want to close us down?
Yep. Thank you, everybody.
Thank you all.
Stay
Thank
safe.
you.
Have a great day.
Yes.
Get
be safe.
vaccinated.
Yes.
There you go.